everyone, welcome. If you'd like to, you could move up a little bit. And then we wouldn't even have to use the mics during the conversation part of the evening. So that would be great. Welcome to all of you. You've come past the very large screens outside. My name is Amy Boski, and I co-direct the Park Street series in Health, Humanity, and Ethics, and it's really a pleasure to welcome you this evening. I want to say a few words about the Park Street series, and just to mention by word of thanks that this series has been enabled by a request from the Quinn family, who have helped us to be able to dedicate a series that's really committed to enlarging conversations around topics in health, humanity, and ethics that seem especially pressing. And I think each year we have a theme. Sort of one of the things that distinguishes the series is that we try to think about one theme around which we thread approaches from really different disciplines. This year's theme has been the common good, and I think you'll agree with me that tonight's speaker really represents this in a most important way, so I'm really, really glad that she can be here with us this evening. But here to introduce her is my colleague in the history department, Professor Martin Summers. So I'm going to call him up to the podium and he will introduce tonight's speaker. Thank you.
Thank you, Professor Boski. My name is Martin Summers, and I am an associate professor of history and African diaspora studies here, and also a faculty member in the medical humanities, health, and culture program. And it is I'd like to welcome you all here this evening, and it is a distinct honor to introduce the historian, scholar activist, and my friend, Dr. Beatrix Hoffman. Professor Hoffman's work, it really goes without saying, is incredibly timely and relevant. For the entire span of human history, societies have associated outsiders with disease. One need only go back a little over a century in the history of our own relatively young country to observe the routine practices of conflating outsiders and disease, and the demonization and political scapegoating that flows out of it. The labeling of Eastern and Southern European immigrants in the late 19th century as carriers of typhoid fever. The characterization of turn-of-the-century Chinatowns as havens for bubonic plague. The defining of African American migrants in the early 20th century as an inherently tuberculous and syphilitic people. The branding of Mexican Americans and Mexican immigrants as the main source of typhus outbreaks during World War II. The scaremongering associated with HIV/AIDS and Haitian immigration in the 1980s, and unfortunately most recently, the fantastical and shameless descriptions of Central American refugees heading towards the southern United States border as bearers of smallpox and leprosy. In addition to outsiders being vilified as threats to the nation's health, they've also been routinely scapegoated as the reason for or potential cause of a faltering healthcare system. To wit, the nativist rhetoric surrounding the mid-1990s political debates over California's Proposition 187, which declared undocumented immigrants ineligible for public welfare and health services. And the proposition's supporters charges that illegal aliens were draining the state's coffers by receiving food stamps, AFDC payments, and free medical care. Or the revived nativism of the Trump era, which casts asylum seekers as people whose sole desire is to come to the US to have anchor babies and take advantage of the expanded Medicaid programs made possible by the Affordable Care Act. And one of the many ironies, not least of which is the fact that undocumented immigrants contribute more economically than they withdraw from the social safety net, is that they are made to bear the blame for a healthcare system that until recently has failed too many Americans, both native-born and immigrant. Professor Hoffman's entire scholarly career has addressed some of these fundamental issues. How has healthcare policy in the United States benefited some at the expense of others? And also, how have people taken it upon themselves to fight for a better healthcare system? Professor of History at Northern Illinois University, Beatrix Hoffman earned her PhD in history from Rutgers University in New Brunswick, where she worked with a prominent labor and women's historian, Alice Kessler Harris, and the noted medical historian, Gerald Graff, among others. She has written over a dozen articles and book chapters, has co-edited a collection of essays, and has written 2 single-authored books, The Wages of Sickness, The Politics of Health Insurance in Progressive America, published in 2001, and Healthcare for Some, Rights and Rationing in the United States Since 1930, published in 2012. Healthcare for Some, her most recent book, which is a comprehensive history of the ways that healthcare has fallen short of being conceptualized as a right and instead has been unequally distributed on the basis of race, ethnicity, gender, and region, was named a Choice Outstanding Academic Title. Her research has been supported by the American Council of Learned Societies, the National Endowment for Humanities, and the Robert Wood Johnson Foundation. Professor Hoffman's engagement with issues of healthcare policy and healthcare activism has extended beyond the academy. She has brought her expertise in these areas to a larger audience by curating 2 exhibits for the National Library of Medicine, one being For All the People, A Century of Citizen Action and Healthcare Reform in 2014, and most recently, Outside, Inside, Immigration, Migration, and Healthcare in 2016. Professor Hoffman's commitment to social justice also shows up in the support that she provides vulnerable students. She is the co-founder of NIU Faculty Advocates for Undocumented Students and has conducted multiple workshops for other NIU faculty on how they can best support their students. Her intellectual interests and sense of ethical responsibility, and I think it's incredibly appropriate that she's a speaker for this lecture series, really coalesce into her current research, some of which she will share with us this evening. The title of her talk is Immigration and the Right to Healthcare. Please join me in welcoming Beatrix Hoffman.
A little shorter. Can you hear me okay? Oh, this is great. This is a great mic. Thank you so much for the kind introduction, Martin Summers. He did mention that we were in graduate school together back at Rutgers. And thank you to the organizers for inviting me to this really beautiful campus. I heard that we're competing with ESPN, so I'm really happy that you all came out here. And I don't know if I ever mentioned to Martin, but I used to live in Boston. I was an undergrad at UMass Amherst. And after I graduated, I lived here for a year and have rarely been back since, so it's really cool for me to be back here. I'm not sure I'm in Massachusetts though, because do you really have a Republican governor now? Dukakis was governor when I lived here. That's how long ago it was. And so I'm really glad that you invited me here to share my research on healthcare and immigration. And as Martin said, I've been writing about the healthcare system for many years, but for a long time the question of immigration, I'm not an immigration historian, but immigration as a category of access or exclusion has kind of been at the back of my mind. And as I was thinking about this talk, I was trying to remember how I came to this interest in the first place, and I realized it actually goes back to my time in Boston. So this was 1986-87. It was the height of the sanctuary movement, which was a time when immigrants and migrants from Central America were being denied asylum in this country. And I worked briefly for an organization called, I think it was the Central America Solidarity Association in Boston. And I realized that that's when I became interested in immigration policy and refugees. And it's even before, I've was thinking about studying the healthcare system and before I became a historian. And here we are, 30 years later, maybe even a little bit more than 30 years later, and some things seem awfully familiar, with Central Americans seeking refuge from violence, demonization of asylum seekers by the White House, but mostly the comparison ends there. When Reagan authorized a legalization process for close to 3 million immigrants back in '86, now we have the collapse of immigration reform, cancellation of DACA, and a zero-tolerance enforcement policy that's bringing fear to immigrants and their communities around the country. It was almost exactly a year ago when agents of the Border Patrol waited outside as 10-year-old Rosa Maria Hernandez was undergoing surgery. And when she came out, they detained her in her hospital room. Rosa Maria was an undocumented immigrant who'd been brought to the US by her parents as a baby, and she also suffered from cerebral palsy. This action violated the Border Patrol's official policy on sensitive locations and sent a clear signal that under the Trump crackdown on immigration, hospitals and healthcare facilities would no longer be off limits to immigration enforcement. And Rosa Maria's case and others like it have important implications for the delivery of healthcare because they serve as a deterrent to people seeking the care that they need. Even immigrants in this country legally are not exempt from what one writer has called the weaponization of healthcare in immigration enforcement. The Trump administration is trying to change the public charge designation, previously that only applied to cash welfare, and apply it to various forms of medical assistance, including Medicaid, the children's health insurance programs, and even to some parts of Medicare. And if this ends up being put into place, this will make legal immigrant families who have used such services ineligible for permanent residency and deter others from applying. And it's not just access to health care, but ideas about health and disease, as Martin pointed out, that are being used to attack immigrants and asylum seekers. As we heard right before the midterm, the bogus claim that migrants in the so-called caravan would bring dangerous diseases across our borders, although apparently we no longer need 15,000 troops to keep them out. These connections between immigration and healthcare raise questions of medical ethics, of human rights, and of course, politics. What I'm doing is looking at the connection as a historical problem. And I want to share with you tonight some of the questions and early findings of my book project on immigrant access to health care. I'm trying to trace the history of immigrants' access to and exclusion from health care, and especially to locate discussions of whether our right to health care is dependent upon citizenship status. And as I go through some of this story, you will see that the connections with the present don't have to be teased out at all. They jump out at us and they demand our attention. But as we history professors are always telling our students, we're looking for both continuity and also for change. There's continuity in how immigrants have been scapegoated as threats to health and burdens on taxpayers, how healthcare policy has been used as a blunt proxy for immigration policy. But also there's been change in how medical care has been delivered or not to immigrant populations, and especially in how immigrants and migrants themselves have fought for their rights in activist social movements. One major example of continuity or a recurring theme is one that has been, of course, again in the headlines today, the stigmatization of immigrants as threats to public health. During the era of mass immigration, when 12 million mostly Southern and Eastern European immigrants arrived just through New York City's Ellis Island, one of the most famous aspects of their arrival was the medical inspection procedure they were required to undergo. And these images were just as familiar to the public then as they are now, and reinforced the idea that immigrants would bring disease to our shores. But in fact, less than 2% were excluded for medical reasons during the entire period of the new immigration from 1890 to 1924. Immigrants were actually in much greater danger of getting sick after they settled in the overcrowded city neighborhoods or were exposed to diseases in the workplaces here in the US. This history of scapegoating, whose targets have changed over time, from Irish to Chinese to Jews to Mexicans and others, always took place in an economic context. Immigrants have been feared, but they've also been demanded by an economy in continual need of cheap and plentiful labor. Immigrant medical inspection was only in part to keep disease out, but it was especially, as the historian Amy Fairchild has argued, to ensure a healthy labor force here. So some of the very first types of care provided to immigrants came through the workplace. Railroad and mining companies began providing medical care for sick and injured workers in the 1870s. And I wondered if we could see in these efforts the origins of an ethos of care for immigrants. But it turns out that the railroad company hospitals in the West refused to treat their many Chinese workers. And this was part of the anti-Asian prejudice that led to the Chinese Exclusion Act in 1882. And racial exclusion and discrimination are, of course, other major themes in US healthcare history. In response to this, some groups who were excluded from healthcare began to create their own medical institutions. Starting as early as the 1840s, immigrants began founding benevolent associations, mutual aid societies, and even hospitals to treat members of their own communities. For example, the Jewish Maternity Hospital, founded in New York City in 1906 at the height of the Jewish migration from Eastern Europe. These immigrant and ethnic facilities originated as a response to discrimination, but many have continued to exist and no longer exclusively serve particular immigrant groups. So many cities, including New York and Chicago, have a Mount Sinai Hospital that was started long ago by the Jewish community. And one of the oldest such institutions, the Chinese Benevolent Association in San Francisco, is still going strong today. One example I know of in Boston is the Beth Israel Hospital, and I'm sure there are many others. And I hope you will tell me more about them. These efforts could be characterized as self-help. Effective as they were that could be characterized as self-help, were based more in necessity and community cohesion than in any notion of more universal rights to care. But this began to change in the late 19th century, when massive labor unrest and the resulting progressive reform movement forced national attention to the rights of workers. And a major leader in forging the connection between immigrant and worker health care was the nurse and reformer Lillian Wald, herself the daughter of German Jewish immigrants, who started the Henry Street Visiting Nurse Service in 1893 to provide home care to immigrant families in the overcrowded tenements of New York's Lower East Side. Wald became celebrated for reaching out to immigrant communities, bringing infant and maternal mortality to the forefront of national attention, and she was credited with inventing the field of public health nursing, a movement that then spread throughout the country. So these are, again, probably familiar images of teeming tenements and the benevolent nurse visiting the family. In settlement houses like Henry Street and others like them, and public health nurses have been seen as part of the push toward assimilation and Americanization of immigrants in the progressive era. That's also been noted for blaming poor conditions on immigrants' own cultural practices and their own ignorance. But Wald was really doing much more than that. In her writing, she argued explicitly that the sickness and death in the family she served was not caused so much by individual hygiene as by the social conditions, and that nurses had a responsibility to not just provide care, but to help immigrants understand their own rights. especially as workers. And it's not a coincidence that Wald, along with many other progressive reformers, was also one of the most prominent supporters of compulsory health insurance, the first campaign to establish a workers' right to health coverage that took place from 1915 to 1920. And this campaign was, of course, defeated. It was backed by President Teddy Roosevelt, but it failed at the state level when it came to a vote due to business interests, but also to the wave of xenophobia during World War I that condemned social insurance as pro-German and un-American. The backlash against progressive reform that destroyed possibilities for worker health coverage then coincided with the Red Scare and the rise of eugenics and scientific racism that led to the national origins quota system of 1924 and the end of the Great Wave of immigration. The 1924 Immigration Act was explicitly intended to cut the flow of immigrants from Southern and Eastern Europe and also to complete the exclusion of Asians, groups that were seen as racially different and a threat to jobs and the American way of life. Yet in this great cutoff that virtually ended all immigration from everywhere except Northern Europe, there was no quota at all placed on the countries of the Western Hemisphere. Even though some in Congress tried to exclude Mexicans on eugenic grounds, agricultural interests in the US continued to need and to demand a cheap labor force that was movable directly across the Mexican border. So the demand for Mexican workers that had started with the rise of intensive agriculture in the 1890s continued in US farms and factories throughout the 1920s. But what happened next brings us back to the theme of healthcare as a tool in exclusion. When the Great Depression hit and unemployment soared, Mexican workers were no longer welcomed. And this began the period of mass repatriation, in which at least 1 million people of Mexican origin were deported or repatriated to Mexico, including many American citizens. The repatriation was motivated primarily by fears of labor competition, but in Los Angeles, where a huge number of these took place, healthcare played a major part. As the historian Natalia Molina has shown, anyone of Mexican origin using health facilities was targeted for deportation. Officials from the county were actually stationed at the LA County Hospital, and when they encountered Spanish-speaking people seeking health care, they would literally round them up and put them on trains to Mexico on the grounds of being a public charge. Molina found that 13,000 people were deported in a 2-year period in this way. So again, just seeking medical care was enough to label families as public charges. The connection between healthcare policy and immigration policy became literal, as a healthcare action seeking care was met with an immigration action, deportation. Except again, the repatriation was far more about race than it was about citizenship. It was about Mexican Americans. It was Mexican Americans who were targeted in Los Angeles, not just immigrants. So when Mexican and Mexican American workers were not needed during the Depression, they were forced out of the country. But then came World War II, and instead of a labor surplus, there was now a severe labor shortage. Workers were needed again, and the US Congress approved the Bracero guest worker program, which was ostensibly a wartime emergency measure, but ended up continuing until 1964. It brought 4 million Mexican workers over this time period on temporary labor contracts. For over 20 years, during and after World War II, US agriculture relied on a system of unfree labor. As US labor unions argued, the Bracero program was. And unions also argued that it created a surplus labor force that drove down wages for US farm workers. And now I'm going to jump ahead a little bit in time to when the unions finally did win cancellation of the Bracero program in 1964. This victory for US organized labor also helped lead to the rise of the United Farm Workers Union. So I realize I've been kind of zooming through a lot of history, but now I'd like to go a little bit more in depth with one case study. And this is of how the United Farm Workers Union and the movement addressed healthcare. Have y'all heard of UFW, farm workers? So in 1966, farm workers joined together and went on strike against grape growers in Delano, California, demanding higher wages and better working conditions and the right to organize. And this was really a big deal because farm workers were the most powerless and exploited in the country and had faced really huge obstacles in organizing for most of the century. The strike in Delano, which went on for 5 years, made the UFW famous because of the new tactics that they borrowed from the civil rights movement, like nonviolent marches and boycotts, especially the world-famous grape boycott, and brought national attention and support for the strike, also making Cesar Chavez into an iconic leader. So medical care comes into the story from the very beginning. Doctors and nurses headed to Delano to provide first aid to the striking workers right in the fields. And union leaflets that were circulated noted that doctors and nurses will visit the picket lines daily. And this first aid service was so popular with workers that the UFW decided to start a permanent clinic, which opened in a trailer at the Delano strike headquarters. The organizer of the clinic was a nurse. Her name was Peggy McGivern, and she ran the clinic full-time. But initially, doctors would only be able to come on weekends, so they would come in from San Diego or LA. And they started going beyond first aid and began providing primary care to workers and their families. So the trailer clinic became such a point of pride in Delano that the UFW brought Robert Kennedy, then Attorney General, to see it when he met with Cesar Chavez and Dolores Huerta for the first time. The next step in the UFW's medical care program was to raise money to open a permanent clinic. And in 1971, they were able to do this. It was built entirely by volunteers. It was named the Terrones Clinic, and it offered complete outpatient and emergency care on a 24-hour basis. They now had a full-time staff, including 4 physicians, 3 registered nurses, and 1 nurse practitioner. Most of the staff only received room and board and a stipend because they were working for the farm workers' cause. And the clinic gradually got enough patients that they were seeing 60 patients a day. The nurses also conducted outreach programs like prenatal classes, diabetes education, and tuberculosis screening in the fields. And thanks to nonstop fundraising, the clinic got its own x-ray machine, laboratory, and pharmacy. Eventually, the donations pouring in would allow the UFW to open 4 more clinics for farm workers throughout California and even one across the border in Mexicali, Mexico. But it was not sustainable to run the clinics completely just through donations when they were seeing that many patients. So as the UFW started to win contracts around 1970, they began to require employers to pay into a new health insurance fund. This was the Robert F. Kennedy Farm Workers Memorial Plan, named after the now assassinated RFK. The Farm Workers Medical Plan was incredibly innovative in the way it addressed the needs of migrant workers because union members could take the benefits with them as they moved from farm to farm. And they could also use their insurance in places where there was no UFW clinic. They could use it to get reimbursed for medical care that they received. It's actually was surprising that historians of farm workers really have not noticed how important healthcare was to the UFW and how connected it was to their mission of not just raising wages, but also empowering workers. So listen to this quote from Cesar Chavez in the early 70s. He said, "The clinic is not given to farm workers like a gift. The same struggle and sacrifice that goes into building a union goes into organizing a clinic. That struggle will go on until every farm worker is protected by a contract and until every farm worker family is assured of decent medical care. And he ended the speech with the chant that the farm workers would use, which is Viva la huelga, which is long live the strike. But he also added, Viva la clínica, long live the clinic. But in this belief in care for every farm worker, ran into a major contradiction in the UFW's program and in Chavez himself, and this was their approach to the undocumented. Cesar Chavez had blamed the importation of Mexican workers in the Bracero program for depressing farm wages, and he saw undocumented workers in the same light. In 1974, the UFW went again on strike in California's Central Valley, but the strike started going really badly. And Chavez blamed an influx of undocumented workers who he said were serving as scabs or replacement workers. And he attacked these workers for degrading wages and also raised the familiar claim that they were bringing diseases into California and that they were flooding local hospitals and clinics demanding health care. And Chavez announced that he was going to start requiring the UFW staff to report undocumented farm workers to the INS, that was the Immigration and Naturalization Service, which is now known as ICE. And he also ordered his staff to investigate undocumented workers' use of local health services. But when it came to these health issues, Chavez actually did not find what he was looking for. So I learned about this campaign. It was called by Chavez himself the Campaign Against Illegals. When I was going through the UFW's archives in Detroit, and I found the reports that the staff members made when they went out and interviewed healthcare providers in Fresno and Merced, California, to say what's happening with undocumented workers in your practice. And some of the things I found that they reported was they found no increase in disease rates, were reported by public health officials. Their discussions with doctors and nurses do not lend support to an argument that illegal aliens cause an increase in disease. And they also found no evidence that undocumented workers were creating a burden on health services in the Central Valley at all. These findings by the UFW staff formed part of a backlash that eventually would lead Chavez to back down from his hardline tactics. But not before the UFW's approach to the undocumented would lead to a new development in immigrant health rights. This took place in Arizona, where a majority of farm workers were undocumented. The UFW actually gave up organizing there, and they left the state in around 1977. Into this vacuum came a new group of activists who would become the Arizona Farm Workers Union. This was completely independent from the UFW. This new union was dedicated to organizing the undocumented workers who made up close to 90% of Arizona's citrus workforce. And they brought a completely new approach to organizing these severely exploited workers who literally lived in the orchards under the trees where they worked, including distributing a Bill of Rights for undocumented workers. The AFW actually began winning some contracts that raised wages for all workers, including the undocumented. And, as you might have guessed, as part of their wider push for community services, they also opened a health center. It was called Clínica Adelante, right outside of Phoenix, and the clinic explicitly welcomed undocumented patients. In this Spanish flyer, they are advertising free medical exams for women. Clínica Adelante, when it was covered in the Arizona Republic newspaper, they quoted Rita Goodman, who was the nurse practitioner at the clinic, and she said, "We don't ask patients if they are a citizen or not. We are here to take care of them." Another important difference from the UFW is that the Arizona clinic applied for and received federal funding, while the UFW's California clinics all ended up closing as the union declined. Clínica Adelante serves the entire community, not just farm workers, and it's actually still going strong today. I see the Arizona farm workers movement as a turning point in the story I'm telling because of the way they clearly define healthcare as a right regardless of citizenship or immigration status. Even though their union did not survive, the idea continued. And the other case study I'd like to share with you is a political battle, actually one that Martin mentioned in his introduction, that took place in California in 1994 over Proposition 187. And this was a statewide referendum that was part of the Republican Governor Pete Wilson's anti-immigrant agenda. And the proposition intended to keep undocumented people, of whom there were 1.5 million in California at the time, from using any publicly funded service, including public education, and also including non-emergency health services. Prop 187, as it was called, its backers resurrected the public charge specter by emphasizing not only that immigrants were taking jobs, but that they were taking taxpayer dollars and public resources. And here's an excerpt from one of Wilson's campaign commercials referring to undocumented immigrants. The announcer says, "They keep coming." Wilson wants to use the money spent on illegals to take care of California's own kids. The measure would also have required public health officials to report undocumented immigrants to the INS. But the proposal had the unintended consequence of galvanizing an immigrant rights movement. Prop 187 led to the largest protests that LA had seen since the Vietnam War, and others as far away as New York. And though much of the opposition focused on the right to education, which by then had actually been guaranteed by the US Supreme Court for undocumented immigrants, it was especially effective for protesters to emphasize the healthcare aspect because of how the denial of non-emergency care could lead to dire consequences. So we see slogans such as Prop 187 kills, referring to the healthcare provisions of the proposal. And possibly for the first time, because of the way Prop 187 targeted healthcare, providers had to take a public stand on immigrant rights, since they were the ones who were going to be called on to enforce the new regulations and to ask people for their immigration status at the point of service. Literature opposing Prop 187 warned that it turns doctors and nurses into immigration agents and that it threatens everyone's health because immigrants would no longer seek care for communicable diseases. So Prop 187 passed. It passed with 59% of the vote, but it was immediately challenged in the courts. And this allowed health providers to avoid enforcing the new law. California public health officials' biggest worry was that people would be deterred from getting care. On the day after Proposition 187 passed, the San Francisco Department of Public Health issued a press release asking patients to please show up for their appointments anyway, and promising that they would not record anyone's immigration status. It seems to me, from the evidence I've seen, it's likely that even without the court challenge, that many health providers would simply have defied the law. Prop 187 turned out to be neither enforceable nor constitutional. The huge protests and the judicial victory ended up backfiring on immigration opponents. And it emboldened immigrant rights movements and even ended Republican rule in California. It was a major turning point in California politics. And I'm not sure I'm quite ready to argue this, but I think that after Proposition 187, that public health advocacy and immigrant rights came together to carve out a limited space for undocumented people to get access to health care on the ground level. And a system of access that used to be clandestine came out more in the open. And I'd like to mention a couple examples of these narrow but important spaces of access. So what types of health care are available for the undocumented by law? So the only universal right to health care for anybody in the United States is the right to emergency care. And this is through a law that's known as EMTALA, the Emergency Medical Treatment and Active Labor Act, which was passed in 1986. EMTALA was not created specifically to provide care for immigrants, but it's been interpreted in that way because no one is allowed to be turned away under EMTALA. And due to the existence of this right, anti-immigrant groups often complain that undocumented people are flooding U.S. emergency rooms. But a recent study showed that undocumented patients do use ERs, but only about at half the rate of U.S. citizens. And hospitals are also able to recoup some of the cost of emergency care for immigrants through a program called Emergency Medicaid, which primarily covers births in the hospital. Another important way immigrants can get health care are federally funded health clinics and health centers, which do not ask for immigrant or citizenship status. There are about 1,300 of these centers around the country. And while they don't exclude, they are also not completely accessible. Many of them charge fees, that they don't offer comprehensive or specialist care, and many have really long waiting lists. Also, many communities simply don't have one. My own town, DeKalb, Illinois, is about an hour away from the nearest federal health clinic. And just a few states have expanded their own Medicaid programs to cover undocumented children only. Currently, just 6 states do this. Massachusetts is one of them. Even if willing to seek them, which many immigrants are not, all of these options put together do not come close to providing any sort of comprehensive access to care. One report has called this Band-Aid care, and we see the outcomes of this when immigrants finally come to the emergency room in advanced stages of conditions like cancer and diabetes or kidney disease. And then there's also official exclusion. I don't know if you remember this from 2009, so back to a short video.
There are also those who claim that our reform efforts would ensure illegal immigrants. This too is false. The reforms I'm proposing would not apply to those who are here illegally. It's not true.
Okay, anybody remember that? So that was the "you lie" moment when President Obama was announcing his plan for the Affordable Care Act to Congress. But as you probably know, Obama was not lying. He, in fact, was ensuring that immigrants would not be included. This was after a lot of political negotiation and maneuvering. Undocumented immigrants were not included in the Affordable Care Act. They cannot even buy into the marketplace plans with their own money under the law, which was passed in 2010. So the undocumented are excluded from all federal health programs, including the ACA, with the few state exceptions for child Medicaid. And since 1996, even legal immigrants have to go on a 5-year waiting list for both Medicare and Medicaid. So exclusion is, of course, a really big part of this story. And what this adds up to is high levels of uninsurance and low levels of utilization among immigrant populations. In 2015, when 11% of US citizens were uninsured, 18% of legal immigrants and 42% of undocumented people were completely without health coverage. Even though the undocumented as a group tend to be healthier than the overall population, the lack of access to care for them can lead to serious health consequences, especially for maternal and child health. Undocumented women receive low levels of prenatal care compared to the rest of the population. And studies have also found a direct relationship between anti-immigration policies and depression, anxiety, and post-traumatic stress in both immigrants and mixed status families, including citizen children with undocumented parents or relatives. Although the exclusions were nothing new, when Obamacare passed, some professional groups began taking a more active stance in favor of providing care to immigrants. The American Nurses Association passed a resolution in 2010 that immigrants, whether documented or not, should have access to quality health care, including the opportunity to purchase insurance, in a direct reference to the ACA exclusion. Another example is the American College of Obstetricians and Gynecologists, ACOG, which made a statement in 2015. ACOG has long supported a basic health care package for all women living within the United States without regard to their country of origin or documentation. Providing access to quality health care for unauthorized immigrants and their children who often were born in the U.S. and have U.S. citizenship is essential to improving the nation's public health. Professional associations have become more vocal about how exclusion affects their ability to care for patients. But even more powerful have been the voices of the immigrant rights movement that emerged starting in 2006 with massive national protests and entered a new phase in 2009 with the Dreamers movement. Oh, I had a slide there that's not there. There's supposed to be a slide of the Dreamers movement there. I believe it's students carrying a banner that says, undocumented and unafraid. So you can just imagine that that's there. Unlike the activism of healthcare providers, this movement has not been on behalf of, but by undocumented people themselves who are refusing to remain invisible. And it's hard to exaggerate the significance of this change in the immigrant rights movement since 2009. Healthcare has not been a top priority for the movement, but more and more we are seeing a connection of immigrant and healthcare rights and the idea of healthcare as a human right. The ACA exclusion has been a force for mobilization. California in 2015 expanded Medicaid to all children, and activists there are continuing to push for the state Affordable Care Act marketplace to allow undocumented people to purchase coverage. Another strategy at the local level brings together immigrant rights organizations with health providers to create networks of hospitals and health centers open to all, as in this Cook County, Illinois initiative, which is open to enroll all uninsured low-income residents, including the undocumented. And I'm going to conclude by mentioning some examples of immigrant health rights activism that may be of special interest to college students, and starting with one relevant to Boston College in particular. And this example focuses on the supply side rather than the demand side of healthcare access. Do you guys know Loyola Stritch School of Medicine in Chicago? So this is a fellow Jesuit institution. In 2014, Stritch created the first medical school program specifically for students with DACA. These students are not eligible for federal loans, but Loyola Stritch, through private fundraising, has been able to create the largest cohort of DACA medical students in the country. And the first of these, 6 students, just graduated this year and are now in their residencies. Some other examples related to college. Following the 2016 election, presidential election, and the rescission of DACA, many campus counseling services were overwhelmed with students suffering from severe fear, anxiety, and trauma. And at my own campus, NIU, the Student Association there is organizing around better access to counselors. And this was inspired by the reports they were getting from immigrant students about the difficulties they were having accessing care, mental health care. And something else that we might not think about, and I actually didn't really think about it until a student brought this to my attention, is that campus health services may be the only point of access for undocumented students to medical care. At NIU, our campus health service, which used to be just run by the university, was just taken over. Things are kind of corporatizing, and a big conglomerate, Northwestern Medicine, is going to be running our student health service, and we just found out that they've decided to no longer provide a gynecologist, to no longer have a gynecologist on staff. So this means that the only source of care for undocumented women students for GYN care has been lost. And students on my campus are starting to organize around this issue. This just happened like last week. So, in conclusion, I'm very excited to be working at the intersection of healthcare history and immigration history. There are a lot of aspects to my project I did not have time to share with you today, and one of them is an idea that I've been kind of germinating about the relationship between the exclusion of immigrants from the right to health care and the reality that the US actually has rejected the right to health care for everybody. So that's what I've been writing about in my other book projects. Why does the US not, we're the only advanced nation that has not recognized health care as a right. But the only, as I said, the only officially recognized right is the right to emergency care. So when we say healthcare is a right only of citizens, that's not even true in the United States. So I think I'm seeing evidence that when immigrants push for access to healthcare, they actually create more openings for rights for everyone, and could be instrumental in achieving recognition of the right to healthcare in this country that has denied it for so long. And I would really love to hear your feedback on this idea, and anything else that you would like to talk about tonight. And thanks so much for listening.